Hepatic encephalopathy is a neuropsychiatric complication of both acute and chronic liver disease. It represents a clinical spectrum from subtle cognitive changes to deep coma. Early recognition and management are important to prevent permanent neurological injury and improve outcomes. Under normal conditions, ammonia absorbed from the gastrointestinal tract is transported to the liver, where it is converted into urea for excretion. When liver function declines due to cirrhosis, acute liver failure, or portosystemic shunting, this detoxification process fails. The accumulation of ammonia in systemic circulation allows it to cross the blood-brain barrier. In the central nervous system, astrocytes metabolize the excess ammonia into glutamine. This increase in intracellular glutamine draws water into astrocytes, producing cytotoxic edema and cerebral dysfunction. Several precipitating factors increase ammonia production or reduce clearance, including constipation or gastrointestinal bleeding, systemic infection or inflammation, hypokalemia and metabolic alkalosis, sedatives, dehydration, or any acute metabolic insult in cirrhotic patients. Hepatic encephalopathy is a clinical diagnosis supported by an elevated serum ammonia level. Diagnosis relies on a known history of liver disease or portosystemic shunting, exclusion of alternative causes of mental status changes such as hypoglycemia, infection, or intracranial pathology, and identification of precipitating factors. In critical care, rapid bedside evaluation of mental status, asterixis, hemodynamics, and metabolic profile is essential. Imaging or electroencephalography may help rule out structural or seizure-related processes if presentation is atypical.
Clinically, asterixis, a flapping tremor of outstretched hands, is characteristic, reflecting impaired motor control. The West Haven grading system classifies hepatic encephalopathy as Grade 1, irritability, poor concentration; Grade 2, lethargy, disorientation, asterixis; Grade 3, somnolence, incoherent speech; Grade 4, coma. Early recognition is essential, as hepatic encephalopathy can progress rapidly from subtle cognitive changes to coma, often reversible with adequate treatment and ammonia-lowering therapy.
The treatment of hepatic encephalopathy combines stabilization, correction of triggers, and ammonia reduction. Begin with airway protection in obtunded patients, hemodynamic support, and fluid management. Correct electrolyte imbalances, especially hypokalemia, and control bleeding or infection. For ammonia reduction, lactulose is a mainstay of therapy. It acts as an osmotic cathartic, acidifying colonic contents and converting ammonia, which is NH3, to ammonium, which is NH4+, which is non-absorbable and excreted in stool. The goal is 2 to 3 soft bowel movements per day. Rifaximin is a non-absorbed antibiotic that decreases urease-producing gut bacteria, usually added when lactulose alone is insufficient or for prevention of recurrence. Neomycin is an older option with similar mechanism but higher risk of ototoxicity and nephrotoxicity. Short-term protein restriction is useful in acute settings but should be avoided long-term. Once mental status improves, dietary protein, preferably plant-based, can be reintroduced. For prevention, manage constipation, avoid sedatives, control infections promptly, and optimize nutrition. In chronic liver disease, secondary prevention with combined lactulose and rifaximin reduces recurrence risk. Hepatic encephalopathy is a reversible complication if recognized early and treated systematically. Quick identification of precipitating factors and prompt initiation of ammonia-lowering therapy can improve outcomes.